Good day everyone. So for today, we will be discussing the case number 3, which is all about the respiratory system. And with that, I'm with my group mates, Ms. Cabrera, Ms. Castro, Mr. Catubag, Ms. Coquilla, Ms. Cortez, Ms. De Castro, Ms. De La Cruz A, Ms. De La Cruz C, and Mr. De La Merced. And for today, this is our outline discussion, which is we will be discussing the case scenario, structure and function, the risk factors, the infection response, the laboratory and diagnostics, the pathophysiology, and the drug study and its teaching. So moving forward to the case scenario, this is a case of 52-year-old female with comorbidity of hypertension. She was admitted due to the complaints of worsening dyspnea, chills, nausea, and vomiting. And for the vital signs, laboratory works up, and diagnostic tests, and even the prescribed drugs will be discussed later as we progress on the report.
According to Haddad and Sharma in 2023, the structure of the respiratory system begins with upper airways, the nose and oral cavity, followed by the pharynx, larynx, and trachea. From there, the airways branch into bronchi and bronchioles, reaching the lungs where gas exchange takes place. The lungs are then split into lobes and contain more than 300 million alveoli. The alveoli are the primary location for gas exchange. The major respiratory muscle is the diaphragm, and the external intercostal muscles assist especially during exercise or respiratory strain. Breathing is tightly regulated by the brain and various sensors, which are the chemoreceptors that monitor blood gases and the mechanoreceptors that sense lung stretch. These adjust how we breathe based on the body's needs. The core role of the lungs of the respiratory system is to exchange gases to deliver oxygen to the blood and clear out carbon dioxide, which fuels our cells and helps maintain proper pH balance. Furthermore, respiration is coordinated through neural networks in the brainstem, which set the rhythm, while sensory feedback adjusts the depth and rate of each breath to meet the body's needs. The lungs, composed of lobes containing alveoli, are affected because pneumonia causes inflammation and fluid buildup in the alveoli, which are the primary sites for gas exchange. This leads to reduced oxygen delivery to the blood and impaired removal of carbon dioxide, explaining the patient's low oxygen saturation and dyspnea. The diaphragm, the major respiratory muscle, and the external intercostal muscles, which assist breathing during strain, are working harder to support respiration, as reflected by her increased respiratory rate. Considering the patient's demographic profile, there are several factors that may increase a person's risk of testing positive for COVID-19. According to studies, older age is strongly associated with higher risk of severe COVID-19, ICU admission, and death. Moreover, age is a major independent predictor of COVID-19 outcomes. While the patient is still a 52-year-old female, the risks begin to increase from middle age. Studies also found that middle-aged and older adults are more likely to have comorbidities and experience severe COVID-19 outcomes, which then reinforces age as a key risk factor for testing positive for COVID-19. Another factor to consider is the patient's comorbidity of hypertension. Based on a systematic review and meta-analysis conducted by CN in 2022, hypertension significantly increases risk of in-hospital mortality, ICU admission, and need for invasive ventilation in COVID-19 patients. Furthermore, studies also concluded that hypertension is an independent risk factor for worse clinical outcomes, including respiratory failure in hospitalized COVID-19 patients. Lastly, though not explicitly stated, adults are often exposed through community, household, or occupational contacts, which increases likelihood of infection.
So for question number 3, we are discussing vital signs of the patient, the result, the normal range, and the possible cause of change. For the vital signs, we have blood pressure of 160 over 100, which is the result is going to be hypertensive because the normal range of blood pressure is 120 over 80, and the client's BP is 160 over 100. So for the possible cause of change, may have hypertension or infection like COVID-19, or fever, stress response from dyspnea, and anxiety. So for the pulse rate, we have 102 BPM. The result is tachycardia because the normal range of PR is 60 to 100 BPM, and the client's PR is 102. The possible cause of change is fever, infection, hypoxia, respiratory distress, and anxiety. And for the RR, respiratory rate, we have 32 CPM. The result is tachypnea. The normal range of RR is 12 to 20 CPM. And the client's R is 32, so it's way off, so it's too high. So the possible cause of change is respiratory distress, pneumonia, hypoxia, and fever, and anxiety. So for the temperature, is 38.8 degrees Celsius. So the result is decline has a fever because the normal range of temperatures are 36.5 to 37.5 degrees Celsius. Possible cause of change, viral infection and inflammatory response and pneumonia. For the SpO2, the SpO2 of the client is 88% and the result is hypoxemia because the normal range is 95 to 100% and the patient's SpO2 is 88%, so it's below the normal range. The possible cause of change is impaired gas exchange from bilateral pneumonia and alveolar inflammation, mucus, or fluid accumulation. That's all.
For the laboratory and diagnostic test, WBC or white blood cell count measures the white blood cells in the blood. Its purpose is to identify conditions related to high or low WBC. For the procalcitonin, it is a biomarker for early bacterial infection, where the purpose is to differentiate bacterial versus viral infections. For the sputum culture and sensitivity, it identifies organisms causing respiratory infection, where the purpose is to guide the appropriate antibiotic therapy. For the SARS-CoV-2 test, it detects COVID-19 infection, where the purpose is to confirm or rule out COVID-19 in symptomatic patients. For the chest X-ray, it produces an image of the heart, lungs, and chest structures, where the purpose is to diagnose and monitor chest conditions. So for the results of the diagnostic test from the patient, the WBC is 7, where the normal range is 4.5 to 11 by 10 raised to 9 liters. The interpretation is normal and is not suggestive of bacterial infection. For the procalcitonin, the result is 0.4 nanograms per milliliters, where the normal range is less than 0.1 nanograms per milliliters. So the interpretation is mildly elevated, but it is unlikely for a bacterial infection. For the sputum culture and sensitivity, the results are pending, and there is no numerical normal range, whereas it is an organism-based. So it will show the causative organism and sensitivities. For the SARS-CoV-2 test, the results are positive, where the normal range is negative, so it does confirm the COVID-19 infection. For the chest X-ray, the results has bilateral pneumonia, where the normal range is clear lung fields, so it indicates an infection in both lungs.
So moving on to health teaching important points prior, before, and after the test. So for before the test, for CBC, explain that the blood will be drawn to check for infection, assure the patient it may cause a brief discomfort, encourage staying relaxed during the extraction. For prolactin, explain it helps determine if a bacterial infection is present and there is no special preparations needed. For SARS-CoV-2 swab, inform the patient that the swab may cause slight discomfort, coughing, or tearing, and also explain that the test checks for COVID-19 infection. And for sputum CS, explain it identifies bacteria in the lungs, instruct the patient to give an early morning deep cough, sputum, and not saliva, and also rinse the mouth with water before collection. And for chest X-ray, explain that test is painless and quick, and remove any metal objects like jewelry, and instruct the patient to take and hold a deep breath for a clear image. So moving on to teaching important points after the test. For CBC, apply pressure on the puncture site to prevent bruising. Explain results help determine infection severity. For prolactin, explain the results guide antibiotic need or adjustment. For SARS-CoV-2 swab, teach isolation precautions like wearing a mask, doing hand hygiene, and limit physical contact. And identify warning signs like worsening dyspnea, persistent fever, or confusion. And also emphasize oxygen monitoring and medication adherence. For sputum CS, inform that the result may take 48 to 72 hours. Explain antibiotics may change based on the results, and encourage them to stay hydrated to help reduce sputum. And for finally chest X-ray, explain findings like bilateral pneumonia means both lungs have infection and inflammation, and reinforce them the need for oxygen therapy and breathing exercise.
So I'll now be explaining why the patient's symptoms arises based on her condition and the natural anatomy and physiology of the respiratory system. So as we all know, the patient is diagnosed with COVID-19 with bilateral pneumonia, and her symptoms such as dyspnea, fever, chills, nausea, vomiting, and even the low oxygen saturation can be explained to the disease pathophysiology. So first, we have the viral entry and the lung infection, wherein the SARS-CoV-2 virus enters through the body through inhalation and attaches to the ACE2 receptors found in the alveoli. Once the virus binds, it begins to replicate and damages the alveolar and the capillary membranes, which are the normal responsible for oxygen and carbon dioxide exchange. And because of this damage, the body activates in an inflammatory response, which is the cytokinase are released, leading to the pulmonary inflammation, edema, and the fluid accumulation, which is inside the alveoli. And this results in the bilateral pneumonia, which can be seen through the patient's X-ray findings. And as the fluid fills the alveoli, the gas exchange becomes impaired. The oxygen can be no longer diffused properly to the bloodstream, causing the hypoxemia, which explains why the patient oxygen saturation of 88%. And in response, the patient develops dyspnea and tachypnea as a compensatory mechanism to increase the oxygen intake. So next is the patient fever and the chills, which occurs because of the infection stimulates the hypothalamus to raise the body's temperature as part of the immune response. And also we can see the tachycardia and hypertension because of the oxygen level are low. The heart pumps faster to deliver more oxygen to the tissues. And this added to the stress from infection and fever leads to the blood pressure of 160/100. And the patient also experiencing nausea and vomiting, which can result from the systematic effect of the virus on the gastrointestinal system or the response to the fever and the medications. And overall, these symptoms arises because of the COVID causes the alveolar inflammation and the fluid buildups, which prevents the normal gas exchange. And this leads to the low oxygen level, increased respiratory effort, fever, and the other systematic manifestation as the body attempts to compensate and fight for the infection. And that concludes the explanation for the question number 6.
Now, moving forward to the drugs prescribed to the patient.
So, I will be discussing piperacillin tazobactam. For the mechanism of action, it involves inhibiting bacterial cell wall synthesis during multiplication. Piperacillin works by killing bacteria while tazobactam protects it from beta-lactamase enzymes, making it a strong broad-spectrum antibiotic. So next is the indication. This medication is commonly used for serious infections, including complicated intra-abdominal infections like appendicitis and peritonitis, skin and soft tissue infections caused by Staphylococcus aureus, and gynecologic infections such as postpartum endometritis and pelvic inflammatory disease. So next is the contraindication. We must remember the contraindication. It should not be given to patients with known allergies to penicillins, citalophosphorin, or beta-lactamase inhibitors. Caution is also required in patients with kidney impairment, seizure disorder, or conditions like uremia, bleeding tendencies, or hypokalemia. So next is the adverse effect. Some important adverse effects includes antibiotic-associated colitis and superinfections, which may present as abdominal cramps, severe watery diarrhea, or fever. Overdose can lead to seizures, especially in patients with renal impairment, and although rare, severe allergic reaction like anaphylaxis may occur. So next is for the pharmacokinetics and pharmacodynamics. For pharmacokinetics, piperacillin tazobactam is given intravenously and excreted by the kidneys. So dose adjustments are needed in renal impairment. Its effectiveness depends on the time the drug concentration stays above the minimum inhibitory concentration. Then lastly, for health teaching, it is important to remind the patient to report an allergic reaction right away. Inform staff if the IV sites becomes painful and seek immediate care if they develop watery or bloody stool, abdominal cramps, or fever even up to 2 months after therapy, as this may indicate C. difficile infection.
Azithromycin is a potent anti-infective and antibiotic agent, classified pharmacologically as a macrolide, specifically an azilide. It is available under the brand names such as Zithromax, Zamax, and Azicite, which is an ophthalmic drug, and can be administered via the oral or intravenous route. So the primary mechanism for action mechanism of action for azithromycin is the inhibition of bacterial protein synthesis, where it achieves this by binding to the 50S subunit of the bacterial ribosome, which blocks the peptidation or the translocation step, thus preventing the translation. It also has a long terminal half-life of 68 hours and high tissue penetration, allowing it to concentrate in phagocytes and deliver high concentrations to infection sites. Azithromycin is indicated for the treatment of mild to moderate infections caused by the susceptible organisms, where in adults, indications include various respiratory tract infections such as the CAP and the acute bacterial sinusitis, and the uncomplicated skin or skin structure infections. It is also used for sexually transmitted diseases or the STDs, including uncomplicated uh, chlamydia trachomatis, urethritis, or cervicitis. And for the prophylaxis treatment of disseminated MAC in HIV-infected patients, common dosage regimens for adults ranges from cumulative dose of 1.5 grams over 5 days for COPD exacerbations to a single 1 gram dose for chancroid. A key contraindication is a prior history of hypersensitivity or allergic reaction to any macrolide antibiotic. Or a history of cholestatic jaundice related to prior azithromycin use. It is also strictly contraindicated in patients with pre-existing conditions that predispose them to the torsades de pointes, such as QT interval prolongation, hypokalemia, or bradycardia. So the most common side effects are the gastrointestinal upset, including the diarrhea, nausea, and abdominal pain, along with the headache and dizziness. The serious adverse effects include QT interval prolongation, torsades de pointes, and potentially life-threatening hypersensitivity reactions like Stevens-Johnson syndromes or the SJS or DRESS. So nurses must assess for signs of infections and obtain specimens for culture and sensitivity before beginning the therapy. A critical intervention involves administration instructions such as azithromycin capsules and Zmax extended release. Suspensions must be taken on an empty stomach 1 hour before or 2 hours after meal. So nurses must also teach patients to finish the entire course of medication and to avoid concurrent use of aluminum or magnesium containing antacids by separating doses by at least 2 hours. Patients must be instructed to report serious side effects immediately, such as chest pain, palpitations, or severe watery or bloody diarrheas. So the overall therapeutic goal is the effective infection resolution confirmed by improvement in the patient's symptoms.
I will be discussing about dexamethasone. It is a long-acting corticosteroid that is used as an anti-inflammatory and an immunosuppressant agent. It treats a variety of conditions including severe allergies, inflammatory conditions, and autoimmune diseases. The typical dosage ranges from 0.5 to 9 milligrams per day. It can be administered orally, intravenously, or intramuscularly. It is contraindicated in patients with systemic fungal infections or hypersensitivity to the drug, and must be used cautiously in pregnancy, lactation, and in patients with diabetes, glaucoma, or heart diseases. The primary mechanism of the drug is by decreasing inflammation and suppressing the normal immune response. It does this by suppressing the migration of neutrophils, decreasing the production of inflammatory chemicals, and reversing increased capillary permeability. It's rapidly absorbed and widely distributed in the body, metabolized by the liver, and has a half-life of about 3 to 4.5 hours. Common side and adverse effects include insomnia, fluid retention, increased appetite, hyperglycemia, and long-term risks such as osteoporosis, glaucoma, spontaneous fractures, cataracts, peptic ulcer disease, and even heart failure. For nursing responsibilities, assessment starts with checking for hypersensitivity to any corticosteroids. We must establish baseline measurements for height, weight, blood pressure, serum glucose, and electrolytes. The nursing diagnosis is the risk for infection. It is directly related to its immunosuppressive effects, which are particularly concerning in the presence of active bacterial or viral infections. With this, the planning and intervention includes monitoring of vital signs at least twice daily, track daily weight, the input and output, checking the serum glucose and electrolytes, assess for edema, and maintaining high alert for any signs of infection. For patient teaching, the patient must never change the dose or stop the drug suddenly. The patient must report signs like fever, sore throat, or sudden weight gain. They should also avoid alcohol, limit caffeine, and understand that severe stress may require an increased dosage of the drug. And they should also avoid exposures to infections like measles or chickenpox. For evaluation, it must show stable patient weight, no fever or edema, the serum glucose and electrolytes are within the normal range, controlled hyperacidity, and the patient reports no signs of GI bleeding.
This slide explains remdesivir, an antiviral medication used to help COVID-19 patients by stopping the virus from multiplying. It is given to hospitalized patients or those at risk for severe illness, but it should not be used in people with allergies to the drug or severe kidney problems. Possible side effects include allergic reactions, infusion-related issues, and signs of liver or kidney inflammation. For health teaching, patients must be reminded that remdesivir is not a cure but may shorten recovery time. They should immediately report symptoms like abdominal pain, nausea, dark urine, or difficulty in breathing, as this may indicate complications.
For the drug study of paracetamol, paracetamol is the generic name with biogesic with its brand name. Its therapeutic classification is analgesics. Pharmacologic classification is para-aminophenol derivatives. For adults, 325 mg to 600 mg per rm every 4 to 6 hours, with maximum dose of 3,250 mg daily. For the mechanism of action, paracetamol produces analgesia by inhibiting prostaglandin and other substances that sensitize pain receptors. Drug may relieve fever through central action in the hypothalamic heat-regulating center. For the indication, paracetamol is used for the treatment of mild to moderate pain and reduction of fever. For the contraindications, contraindicated in patients with hypersensitivity to the drug. Use cautiously in patients with liver disease, G6PD deficiency, malnutrition, dehydration, or renal impairment. For the side and adverse effects, these are the examples posted above. For the pharmacokinetics and pharmacodynamics, for the route per rm orally, onset less than 60 minutes, for the peak 1 to 3 hours, and the duration is 4 to 6 hours. Rapidly, completely absorbed from GI tract, widely distributed to most body tissues, metabolized in liver, and excreted in urine. And its half-life is 1 to 4 hours. For the nursing responsibilities, prior to paracetamol administration, assess vital signs, medical history, and hypersensitivity to the drug of the patient. Exercise caution to prevent dosing errors, confirm the total daily dose that not exceed limits, and adjust for liver or kidney impairment of the patient. Verify doctor's order and patient identity before administering the drug. Ideally, while the patient has a fever. Post-administration, instruct the patient to report any side effects, monitor temperature every 2 to 4 hours, and encourage fluid intake. Evaluate for fever relief and adverse reaction. For the patient health teaching, patients should seek medical consultation if paracetamol use extend beyond 10 days or if fever persists for more than 3 days. Immediate medical attention is advised for severe or recurrent pain or high and continuous fever, as these symptoms may indicate a serious underlying condition. The daily dosage of paracetamol should not exceed 4 grams or 3 grams if using over-the-counter formulations, and avoid using of alcohol when taking the medication.
And these are the references we use in this case presentation. And that's all. Thank you for listening and have a great day.